Good afternoon, everyone, and welcome to today's conference call. My name is Dr. Astral Webb, and I am the Director for Health and Family Services at North American Management. We want to welcome all of you to today's call. The purpose of our call today is to learn more about how HRSA and ACL grantees are working collaboratively to improve senior health care for those seniors in your communities. We are delighted today to have our area on agency administrators, our state units on aging, primary care associations, and health center programs join us today. So before we begin, I do want to acknowledge and thank HRSA under the leadership of Tiffany Smith, who is a branch chief at the Office of Special Populations, and Lieutenant Commander Kevin Bates, who is our current project officer for our national corporate agreement with HRSA. Under this corporate agreement, without it, we would not have been able to do the work that we're doing right now for senior health and for the Health and the Aging Project. In addition, I would like to recognize as well our ACL partners and AOA administrative personnel who have been working with us diligently, closely with HRSA, and that is Chris Nichols, Greg Case, and Michelle Washko. They have worked diligently with us in their leadership so that at the federal level, working collaboratively with HRSA, that we're able to connect and do what we can locally for our community health centers and the local aging networks. So I would like to also recognize that we have a phenomenal group of panelists who will just be, for a few minutes, sharing what's happening because of this partnership, the HRSA-ACL partnership, what's happening at the federal level, the national level, the state level, and the local levels. So we're really delighted to have all of them join us, and you will hear from each of them individually during the call. But before we go on, I do want to recognize that this is a regional call for all of you in Regions 6 and 8. This will include the following states: Arkansas, Louisiana, Oklahoma, New Mexico, Texas, Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. So again, thank you all for joining us this afternoon. This call will be about an hour long. We will have an archive version available on our website at the end of the call, which you can get at www.healthandtheaging.org. It's all one word, and we will also send a recording out to all of you who participated by email.
Also, Dr. Webb, we have Percy Devine and Dr. Princess Jackson and Derek Lee from Dallas on the call.
Oh, wonderful. Thank you all for joining us today. And so, Percy, I guess with that, I would like to invite all of you, as I know you're the regional AOA administrator for Regions 6 and 8. And so I would like to ask you if you can just share a couple of words about how important this partnership is for your region.
Sure. Thank you. Oh, you bet. Over the last year and a half, AOA and ACL has been working with the HRSA regional offices and the State Unit on Aging directors to get to know the primary care associations within our 11 states. The Assistant Secretary, Kathy Greenlee, has put an emphasis and a priority on improving the quality of life for older adults and people with disabilities. I've had the opportunity to work with Dr. Webb with North American Management for the last year or so, and just appreciate her coming over and working with AOA. In addition to, I have Dr. Princess Jackson here with HRSA, the regional administrator out of Region 6, and also Patrick Gillis, regional administrator out of Region 8, in addition to Nick Zacconi. And we've been working hard to have AOA, Aging Network, and the HRSA network get to know each other. Some of the basic goals have been to try to enhance the aging network and the HRSA network and working better with each other so that individuals will have more information and knowledge about our aging service network and our senior centers, in addition to improving access and knowledge of the Primary Care Association and the federally qualified health centers that are out there. Special note to North Dakota, they have been moving forward. I know the Primary Care Association as well as the State Unit on Aging, they've been meeting together to see how they can better work their offices and their networks together to improve access for care. Once again, thank you, Dr. Webb, and also Rick out of headquarters for all your work in the past. Thank you.
Thank you so much. And I do believe we have Lance Robertson on the line as well. Lance is the president of the National Association of States United for Aging and Disabilities. Lance, are you on the line as well?
Yes, I am here. Thank you, Dr. Webb.
Thank you.
And I know, thank you, just for a couple of minutes, you had asked for just a few comments regarding what we're doing here in Oklahoma, and I'm so glad that Mr. Devine's on the phone. Our bi-regional administrator has been a true leader in this regard. He's really been encouraging us as states to certainly step forward and take a very aggressive approach in trying to build what could be a very important relationship within each state between HRSA and the state units on aging. We had a Region 6 and 8 meeting there in Denver under Mr. Devine's calling and leadership this past July, and at the meeting he had Mr. Gilius was there, the regional administrator with HRSA, who I really recall quite vividly the amount of information that he shared relative to HRSA and just the hundreds of programs that's under that umbrella and the opportunity that is there for synergy and collaboration. And I remember leaving pretty pumped up to try to get started on building or further strengthening that relationship here in Oklahoma. So we came back and we had a meeting, and Dr. Princess Jackson was able to join us by phone, and a representative from the state PCA was there, and we had what in my 5.5 years here was kind of the initial meeting to kind of get that ball rolling. And we, though admittedly haven't had the time this fall to really capture and move forward from that meeting, but I know for 2013 that will be a priority for us because I see, again, a lot of opportunity for those we collectively serve. So we're excited about that. I know as far as FQHCs go here in Oklahoma, we don't have that many. We have, of course, some large ones. We have a large one here in Oklahoma City, the Mary Mahoney, and you know, we do plan again to put some energy into that relationship for calendar year 13. And again, we're excited about this call and anxious to hear more information. So thank you, Dr. Webb, for pulling this together and just for an opportunity to listen in and again, help where we can. Thank you.
Thank you so much, and thank you all for your time, for your leadership in the area, and that has meant made all the difference in the world. I do want to share just for a couple of few points about what's happening in your region so that you understand what's happening in Regions 6 and 8 across the entire board. With all the 11 states, currently there's a total number of the patients that are being served in that region is in the ballpark of 2,572,000 patients there who are being seen currently under the healthcare system. I should say actually through the community health centers. And so the total number of health centers that we have in your 11 states is 188. And we know that the total number of seniors throughout that region right now, roughly, is about 185,000 individuals. So what we can see is that there are truly a large number of seniors who still can benefit from receiving health care services in your regions. And we do have a significant number of health centers there. There are 188, and our hope is that all of them will be connected with an area agency on aging or some form of aging network so that they can provide a lot of the non-clinical support that they need to address the senior health issues. I do want to highlight that in that area, that Texas has the greatest number of patients currently being served through the community health centers. Most of their patients, they have the greatest number of senior patients, and they actually have the most number of health centers in that area that are funded through HRSA. So although New Mexico Health Center programs serve fewer total number of patients than Colorado, they serve more seniors. So one of the reasons we wanted to make sure and bring that out is that especially for those health centers and the aging networks in those areas, we wanted you to be sensitive of the fact that it is growing, it is what we're learning, and the models that are coming out of those areas would be the ones that we would love to see replicated across the entire region in Region 6 and 8. So we here at North American Management, we are funded partially through a corporate agreement with HRSA to provide training and technical assistance to our health centers who want to increase access and capacity to care for seniors, as well as to eliminate health disparities in providing that care. So it is important for us as we were working to make sure that we can provide all the expertise and the opportunities for our health center grantees to really work with find out who our collaborative partners could be. And we have been delighted to work with numerous state and national organizations that have made this possible, and many of them you've already kind of heard from the regional leaders in those areas, but later on we will hear from one of our collaborative partners. So before I introduce them to be on the call, we do have a couple of HRSA grantees and aging networks on the call who have been really diligently already working together or providing some critical services for seniors in your area. So I would first like to introduce Brenda Kennedy. She is the Quality Director at Our Care Health Center located in Arkansas. Brenda, thank you so much for joining us, taking the time off from your busy health center. And if you can just share with us for a few minutes what you're doing with senior care, we would greatly appreciate it. Thank you.
You bet. Thank you for the invitation. Well, Our Care has a really large elderly population, and we are in mostly very rural areas. And of course, these are in very small towns where a lot of the younger population is leaving the counties, leaving a primarily elderly population there for us to serve. And, of course, being in part of the Mississippi Delta, we have high rates of diabetes, cardiovascular disease, and even cancer. So we've got a lot of chronic illnesses that we're trying to manage. And, of course, here in this area, we also have a lot of patients that are uninsured until they're of the age to be eligible for Medicare, and so we see a lot of this aging population coming to us with a lot of illnesses that have not been well managed over the years because they didn't have affordable access to care in a lot of areas. As far as the services that we provide, of course, we provide the basic primary care services. We have 27 medical sites and one mobile unit that we can take around to different areas to provide services. We have a couple of wellness centers, a diabetes self-management education program, 2 pharmacies, a medication assistance program where we try to help seniors as well as other patients of ours access pharmaceutical companies for free medications. We also have a Silver Sneakers program, and we do provide a transportation program, although that is limited because we only have 2 vans. And as you can imagine, when you're trying to provide services to 27 sites, that's not going to go very far. We have some excellent linkages with our local nursing homes. Many of these, we're very close proximity to those facilities, and so we see those patients from the nursing home as well. And in fact, in one of our local nursing homes, we were partners with them to help implement a dialysis center in a brand new facility that they opened up there a few years ago. State-of-the-art, beautiful. It is part of the grounds of the new nursing facility, and so it provides a much closer place for our patients to go and have those services rather than having to drive an hour or more to have that dialysis. We've also worked closely with senior centers in the past to provide education programs and go to those senior centers and provide vaccinations and things like that so that they didn't have to come into our centers. We'll also work closely with home health agencies and making sure that our patients have the access to those services that they might need. And one of the partnerships that we've been really proud of that has really helped in the areas that we have had that implemented is with our local School of Pharmacy. They began a new College of Pharmacy here a few years ago, and we were able to work with that new program to obtain clinical pharmacy services on a limited basis, and we used those services to help provide education and assessment of a lot of our elderly patients with multiple chronic illnesses, especially those that were not under good control or weren't having the treatment outcomes that we were hoping for. And they provided us with assistance for pillbox training and, looking at potential adverse drug events and adverse drug events and things like that so that it didn't take additional provider time to go into that depth of detail with the patients. We also are co-located and linked with community mental health centers, and so we have those services that are provided in a seamless fashion to our patients. As far as needs, as you can imagine in rural parts of the country, access to specialty services is really hard to get, so we don't have geriatricians anywhere close by. There are also limited services available as far as cardiology and neurology and all those other things, and so that makes it difficult for us to be able to get our patients to those services in a timely manner. It may take us 6 or 7 months to be able to get a patient an appointment. We also have, the intensity of the service that is needed to successfully manage these patients. And when you are trying to meet the demand of the patient volume that we have, and as well as take the time needed to individually educate and assess these patients and spend the additional time with the patients and their family members, it really gets difficult with some of the staffing issues that we have and things like that, because in many of our locations we're the only provider in town, and so we're the ones trying to cover and meet all of that demand. Then along with that additional intensity of services, we don't have reimbursement for a lot of the non-physician services that we try to provide. And so there again, like with the clinical pharmacy, nutrition education, case management, patient navigation, all those types of things, those are very time-intensive services that we are not fully reimbursed for. And then, of course, we hear a lot of times from our seniors that the out-of-pocket expenses, especially for medications, is just a huge barrier for them. And, we hear all the time that they aren't taking their medications because it's a choice between eating or taking their medications. And that's where our medication assistance program goes into effect to try to cover that gap. But again, that's only for long-term medications because of the time frame. It can take up to 8 weeks or longer to actually get those medications from the pharmaceutical companies. So, those are some of the barriers and things that we have seen over the years, and we are just continuing to see those things grow as we have more and more of the elderly population coming to us. And then, in some of the larger towns that are surrounding us, the providers there are not accepting Medicare and Medicaid patients any longer. And so that, again, is increasing the demand for services at our facilities.
Great. Thank you so much, Brenda, for sharing that with us. I think it was real. I'm sorry? Hi, Brenda?
Yes.
I think. Okay, great. So we have you there. Thank you so much for sharing some of that work that you have been doing there in our care. We know that it is very, very challenging for many of our grantees, and I think in many, many ways these are some of the things that our aging networks are able to provide in support of that as well. So, all right. So I'm going to now like to introduce our next speaker who will just share some information with you, John Becker. John, are you on the line as well?
Yes, I am.
Okay, great. And so John is going to share a little bit about one of the partnerships he has with an FQHC in his area. John, thank you so much for joining us today as well.
Oh, no problem. I appreciate it. I work for Senior Services Plus in Alton, Illinois, and just a little background. Our agency is located in Madison and St. Clair County, which are the two largest counties outside of Chicago and Illinois, and they're considered part of the St. Louis metro area. Our agency is a large senior service provider. We serve over 30,000 folks a year. We do Meals on Wheels. We do a lot of partnerships with the area agency in our region, and that's information and assistance, limited transportation, congregate meal sites, and we also have a very large community care program or in-home non-medical homemaker type program that we contract with the state of Illinois for. And probably about 3 years ago, when we started seeing the coming of managed care in the state of Illinois for dual eligible individuals who are receiving Medicaid and Medicare, it was actually implemented in 2012. We realized that for that reason and many others, we had to start to seek out a partnership with and I just think of it as a medical group, a non-for-profit that really kind of shared our core values and our mission. Like many senior centers or social service agencies that serve seniors, we get a lot of requests from for-profits to come in and provide services, home health, elder abuse, our elder law attorneys, people that are coming in to get access to our referral base, which is large. And we're very selective about who we partner with. Southern Illinois Health Foundation was somebody we approached 2 years ago because they are a extremely large provider of services in clinics. They operate pharmacies, and our local mental health providers, they have the same values in terms of the people they're trying to serve, low income, of which that includes elderly or seniors. So it was a very natural partnership for our agency. Although we have a large non-skilled medical, we do not provide home health, and we're not or in the foreseeable future, going to start up any kind of skilled medical services. So finding a FQAC that mirrors what our mission values are was very important, and the Southern Illinois Health Foundation has been a tremendous partnership for us. It's initially started with us having a home health provider that we could essentially trust to work with our seniors that we're doing non-skilled medical for. So we started with a referral base back and forth with them, and it evolved into quite a few things, actually. They rent an office in our facility, and at our main facility in Alton, we have a fully outfitted wellness program, which is commercial-grade gym equipment, exercise classes, and we offer it based on our mission, which is to provide affordable wellness for people in the community. So it's $100 a year. Having a medical provider in the building with us, they provide a nurse that does blood pressure checks. They also come in and do a lot of the ancillary services that seniors are looking for, the flu shots, pneumonia, balance prevention, or balance screening, fall prevention, that kind of thing. It really started small and started to build from there, because in turn they operate 32 clinics in 2 counties. We started a trade and office space to have our homemaker staff in a urgent care facility of theirs, and they operate a hospital and a large senior living complex. We have staff there for homemaker services, but we're also going to start doing community-based exercise classes for their senior population. So the partnership for us has been really good, because we don't provide those medical services, nor are we going to. That's not within our capability. Having a partner that has provides quality services and has a good name coming in and providing those services, which for the managed care that's coming in Illinois is very important to us. It's not only been beneficial for our seniors, they also provide services, like many providers, for many of our staff. And we have over 300 employees, of which many are single moms that have Medicaid or Illinois health insurance cards that receive services through the Health Foundation. So it wasn't just our client population of seniors. Many of our staff were eligible for some grant-funded activities that the Health Foundation does. In addition to the partnership that we've developed, what I didn't realize before I started working with the Health Foundation, a very low percentage of their client base were seniors, 7 to 8%, and a lot of that had to do primarily with the fact that the senior population go to their primary care physician and they stay with them for a long time. What we're trying to change and have started to change with that is to expose seniors who are low income or at a poverty level to medical options that they may have not known about before. Because one thing about our specific area, Madison County, and I'm not sure that a lot of people know about it, in 2008, we were considered one of the worst counties for doctors to do business in because of the legal system we have, and we had a lot of physicians leave the area. That has reversed itself, but there was a real need for seniors to find primary care physicians, and from 2010 until now, the Health Foundation has been a big part of that. The information that we trade back and forth we have a very active information and assistance program funded by area agency. A lot of the services that we talk about now as far as assisted living or affordable housing or primary care physicians or other things, we refer directly to the Southern Illinois Health Foundation. And they get, like probably many of the medical providers, they get grant opportunities that we can't apply for. And that has developed into a whole nother partnership of grant writing. We provide wellness services here at the facility, but at 3 different locations at senior housing. And our expertise in the wellness area, combined with their background for medical services, has allowed us to start brainstorming and looking at applying for large regional grants to access or provide more access for seniors for wellness. It's been a great partnership, and quite honestly, when we first started discussing it, our biggest issue came up was to develop a partnership proposal that help avoided any violation of the Stark laws. And their attorney and our attorney were able to craft that and put it in place. And, that was just one of those check-off list things that you had to do. And once we got past that, there are so many things we're doing together now. It's a great relationship. And I see a lot of possibilities for us and them down the road.
Thank you so much, John, for those words. I think just the lessons learned that through these partnerships between the health center programs and the aging networks, they truly, really work and make a difference in those communities. So I cannot say it enough that how important this kind of collaboration that started with HRSA and ACL at the federal level has made such a great difference. And as we've seen these the relationships actually at the local level, we really, really understand how we better can work together. So, John, thank you so much for sharing that. I think we're supposed to also have Dr. Robin Yasui from the Denver Health Medical Center as well on the call. Dr. Robin, are you on the line with us as well?
Yes, I am.
Okay, wonderful. So I'm just going to kindly ask you if you can just share for a few minutes what's happening with Denver Health Medical Center and the senior health issues that you encounter as well. Thank you.
Yes, I'm the Director of Geriatrics at Denver Health, which is a large FQHC in Denver. The majority of our patient population is our Medicaid patients and Medicare as well, and Colorado Indigent Care Program patients, and a large percentage of uninsured. Therefore, probably our greatest issue at Denver Health at this point, because so many patients are uninsured or have limited abilities to access private sector physicians who are still willing to take Medicare and Medicaid patients, is our biggest challenge is access. Patients, we have wait lists at all of our community clinics, patients trying to get in and establish primary care with us. We have a large clinic at the main hospital as well as community centers scattered throughout Denver so that we can be accessible to patients with transportation limitations. We also have the 911 system, help with the Rocky Mountain Poison Center, the school-based health clinics in Denver, the paramedic training system, and our affiliates. We are in affiliation with the University of Colorado, so we also do a large amount of teaching and training at Denver Health of medical students, nursing students, pharmacy students, and many other students from the healthcare disciplines. In our system currently, we see approximately 6,000 to 7,000 seniors as primary care patients. my clinic in particular, we've designed to be the complex senior clinic so that the most complicated seniors who have a variety of not only medical issues but psychosocial issues will come to my clinic predominantly to be seen for primary care. And at my clinic, I'm very fortunate to have a phenomenal, dedicated geriatric social worker, an RN, and I mentor the psychology training program, so I have psychology residents with me, and I also mentor the pharmacy program, residency program for primary care through the University of Colorado, and I teach pharmacy students from Regis University. Therefore, I have staff from those disciplines assisting me in my clinic. So our patients, I believe, are lucky in that they have access in one primary care center visit to social work, psychology, and pharmacy counseling. Our patients are extremely diverse in that my patients alone in my complex senior clinic currently hail from 55 different countries. And we use the AT&T translation line system in the clinic so that we are able to access real-time interpreters via speakerphone whenever we see these patients from very diverse backgrounds. Our patients also have, unfortunately in the complex clinic, about 65% cognitive impairment and about 35% illiteracy. So, of course, the challenges are providing services when you've got cultural barriers, language barriers, cognitive barriers, and literacy barriers. But that's also a very rich clinic for us, and so it's a very rewarding setting in which to work. Denver Health also, fortunately, once you're in for a primary care, as a primary care patient, we have access to all the subspecialty clinics without barriers to our patients, which is very fortunate. So they're able to be seen by any of the medical subspecialists and surgical subspecialists that we deem needed. We, as I mentioned too, because we're out in the community, those patients who are seen at other community clinics in the Denver Health Network are also able to access those same subspecialists and the social work support and psychology and pharmacy support by coming into the Denver Health Senior Primary Care System. We do not currently have an affiliation with long-term care or nursing home care, but it is something we're actually looking at this time. And we don't have as many networks, I don't believe, as I'd love to see down the road in the community, partially because, again, we're not needing to pull in more patients. We are actually trying very hard to get the patients who are waiting to see us into our system to be seen. We have pharmacy and radiology access for our seniors on site. We have a small transportation budget to also allow our patients a little more ease in accessing us. And we also have a large managed care program. About half my patients are enrolled in our managed care program, which offers care management, transportation, mail-out pharmacy services for these patients, as well as a lot of wellness programs and other type of psychosocial support. So I think we're very fortunate in Denver at Denver Health. It's going to be a struggle to see, of course, as the population continues to age. It's going to be a struggle to see how we can continue to provide this level of support, and that's where I hope that we will be able to partner more with some community resources as this population grows, and their need to access primary care and the associated services will also grow.
Thank you so much, Dr. Robin Yasvi, and especially for your work that you're doing there. You're doing a tremendous amount of work at Denver Health, and we know that it's working. And so through the partnerships with most of our health centers, as you all alluded to earlier, in providing that medical home, truly that team approach, that partnership, that community mobilization is really, really critical to make it work. So thank you for all that you're doing for those seniors that you serve. And so I would like to invite now Mary Walsh from the National Council on Aging, which has been one of those organizations that has really been our partners, truly trying to get resources shared to our grantees on the various aging networks at every level and what they're doing. So now that we've heard some of the challenges and the successes of our grantees, Mary will kind of give us a little overview of how the services that are available through the aging networks for our health center programs in supporting their work in senior health. So Mary, thank you so much for joining us as well this afternoon, and I will now turn it over to you. Thank you.
Thank you, Kestrel. I am with the National Council on Aging, which is a private nonprofit service and advocacy organization with the mission of improving the lives of millions of older adults, especially those who are vulnerable and disadvantaged. Within the National Council on Aging is the Center for Healthy Aging, which is the National Resource Center for the Administration on Aging around evidence-based programs. The Center for Healthy Aging has the mission of improving the health and reducing disability among older Americans. And to do so, we collaborate with a number of organizations at the federal, state, and local level. We identify, translate, and disseminate evidence-based programs that are proven to work. We promote community organizations who are the essential agents to improve the health of older adults. We reach out and engage diverse elders, and we advocate for the support of strong and effective community programs. We're all aware of the aging of the population here in the United States, so I won't dwell on that. But we have the younger old population, and those are the baby boomers, who many of whom started reaching retirement age in 2011. Over the next 20 years, 74 million boomers will retire, so that every day, 10,000 or so new retirees will be added to Social Security and Medicare. At the other end of the spectrum, we have the oldest old, which are those who are 85 and older. And the fastest growing segment of the total population is those who are 80 and over, with a great growth rate that is twice that of those who are 65 and 4 times that of the total population in the United States. That group now represents 10% of the older population, and it's going to triple by 2050. The Administration on Community Living, Administration on Aging, is one of our strongest partners with the Center for Healthy Aging. The Administration on Aging recently became part of an umbrella organization called the Administration for Community Living, which also involves the Office on Disability and the Administration for Developmental Disabilities. The mission of the Administration on Aging has been to help older adults maintain health and independence in their community, and that has broadened now to include individuals with disabilities of all aging. The Administration on Aging began in 1965 with the passage of the Older Americans Act because legislators felt that there was a lack of community social services for older people. There is now a network through the Administration on Aging that includes 56 state agencies on aging, 629 area agencies on aging, more than 20,000 service providers, and a number of tribal organizations. One of the newest programs in the Administration on Aging is the Aging and Disability Resource Centers that are known as the ADRCs. And those offer one-stop access to older adults, people with disabilities, family members, caregivers, to programs such as care transitions, Alzheimer's and caregiver support, veteran services, meals and rides, benefits access, options counseling, and evidence-based programs, including the Chronic Disease Self-Management Program, which I'm going to talk a little bit about now. Evidence-based programs are proven tools that deliver health benefits to participants and can help change systems for older adults so that they become activated self-managers. The Administration on Aging has, over the years, supported evidence-based programs with several funding opportunities. From 2010 to 2012, there was a funding opportunity through the Recovery Act for 45 states, Puerto Rico, and the District of Columbia to either start chronic disease self-management programs or expand existing programs. Just this past September, the Administration on Aging began a new funding opportunity to 22 states. And those programs will embed evidence-based self-management programs into health and long-term care services and supports. So those states that receive this grant, these grants, are charged with significantly increasing the number of older and disabled adults who have chronic conditions to complete chronic disease self-management education. The role of the Center for Healthy Aging in this, as the resource center, is to provide rapid, targeted assistance to grantees, to provide technical assistance that's targeted at performance improvement and knowledge of best practices, to document and report nationwide participation and capacity, and to conduct a national study to document individual outcomes associated with chronic disease self-management programs. And to do that, the National Council on Aging works with federal partners such as the Administration on Aging, Center for Disease Control, HRSA, Substance Abuse and Mental Health Services Administration, and the Centers for Medicare and Medicaid Services. At the state level, NCOA is working with state units on aging, state public health departments, and state Medicaid offices. And at the local level, there are over 6,000 host and implementation sites that include organizations like the Area Agencies on Aging, healthcare systems, senior centers, senior housing, faith-based organizations, multicultural organizations, and many others. A few examples of the evidence-based programs that are recognized by the administration are, for physical activity, there's an arthritis exercise program, and there's also a walk with ease program. And around self-management, there's the chronic disease self-management program, the diabetes self-management program, and self-management programs for pain, for chronic pain, for HIV, and there are also some online programs that are offered. In terms of caregiver support, there's a stress-busting program for caregivers, and there are also programs for caregivers of those with Alzheimer's. For depression management, there are several programs that deal with depression. And behavioral issues, there is a program for the prevention and management of alcohol problems in older adults. We're all very aware of the risk of falls to older adults and the damage that those falls can do. And there are several fall risk assessments and reduction programs, including a matter of balance and Tai Chi. There's also a medication management program. I know a number of you are involved with patient-centered medical homes and the recognition as patient-centered medical homes. And there are some critical junctures where chronic disease self-management intersects with the recognition for patient-centered medical homes. There's a role for patient self-management and also practice self-management support. There's the need to document self-management capacity, self-management goals, and to provide tools and resources. There's a need to counsel on healthy behaviors, to assess, provide, and arrange for mental health and substance abuse treatment, and also to provide community resources. PDS-MP can be a component of the patient-centered medical homes standards, especially standard number 3, which is around planning and managing care, and standard number 4, which is to provide self-care support and community resources. In addition to the other things I've mentioned, the National Council on Aging is also working with community organizations and area agencies on aging around recognition of the Diabetes Self-Management Initiative for accreditation by the American Diabetic Association and the American Association of Diabetes Educators. There already are 2 sites that have successfully been recognized. Just speaking briefly again about falls, there's a falls-free initiative with which 46 states cooperate, and there's a lot of good information on risk assessment and falls prevention for older adults. The National Council on Aging has a number of online tools for building systems. We have a website, which is www.ncoa.org, that has a lot of information about lessons learned, best practices, and replication reports for chronic disease self-management. We've got online training modules, calculators for the cost of chronic disease self-management programs, information about sustainability, fidelity, quality assurance, and a number of templates as well as webinar recordings. I have some PowerPoint slides of this presentation, and Astral is going to make them available. And a number of the websites and information that I've mentioned today will be up on that will be available through Astral. So thank you very much for your time, and it's fascinating to hear about the collaboration between area agencies and federally qualified health centers. Thank you.
Thank you very much, Mary, for sharing that information. And we have almost all of the resources and the opportunities she has shared. We have actually had most our health centers actually benefit from the training, the resources, and the opportunities. So we want to continue to thank all of our aging network and our aging partners for all their work and the resources that they have that are available to our community health centers. We do want to let all of you know that we are planning to have our National Annual Symposium in April in 2013 in the Washington, D.C. area. So we really want to encourage you to please visit our website as well at www.healthandtheaging.org, all one word, and sign up on our mailing list as well to get our announcements, to get our alerts so that you are aware. We do have a call for abstracts out, so we always encourage our grantees, our health centers, as well as the aging networks who have been working with the health center programs funded by HRSA to really share their best practices, the lessons learned, and even some of their own challenges so that many of the other grantees can learn from them. So this is a phenomenal opportunity as well for the aging networks who will be attending the conference for NCOA to be here during our national symposium to really connect, get to learn one another and meet on the ground level and start those collaborations and partnerships that turn out to be, as you heard from all of our presenters today, pretty much very successful. I do want to thank all the leadership at HRSA, ACL, AOA. Many of the AOA leaders you've heard earlier on today, I want to thank all of them for being on the call. We know they're extremely busy, and they have been there to share because of what's happening in Region 6 and 8. We think there's an opportunity. I want to thank Brenda Kennedy from Arkansas, Dr. Robin Yasui from Denver Health, and John Becker from Illinois for sharing all of the work that you're doing with seniors, whether it's directly on the medical side or the non-medical side, even through the partnerships and the collaborations. I think many of us, especially health centers and the PCA partners who are on the call today, have really understood how this partnership is working. And so I want to thank you again for taking the time out for being on today's call. I think it's important for all of us as we look at this aging baby boomers, the population coming out, that we really need to understand that there are innovative and creative ways that we can really address a lot of these needs through these kind of collaborations between the HRSA grantees and the ACL, AOA grantees. So we are really delighted to work with everyone here. We have done a tremendous number of webinars, and I really encourage you to look at our website as well for opportunities. Many of our grantees, whether they're health centers and some of the AOA grantees, have actually participated on many of these webinars and opportunities as well. We worked really closely with our national players again to provide monographs and fact sheets. We will be coming out. There are a couple we're working on now that should be released soon, and we're doing it in collaboration as well with HRSA and ACL, AOA. So we're really excited about those and the opportunities. This is the beginning of a wonderful working relationship, especially for what's happening in Regions 6 and 8. Percy Devine and Lance Robertson, I know you guys co-lead in that area on the aging side. We want to thank you for that. I know we have Dr. Jackson, I think Ms. Giller, and Nick Zacconi on the line as well. So thank you so much for all your leadership efforts and all that you're doing. I thank you, everyone, for joining us on today's calls. If you have any further questions, feel free to contact me directly. I will give my number, 703-812-8822. For the health centers that would like to connect with an aging network or vice versa, an aging area agency on aging or an aging network that would like to connect with a health center program, please feel free to contact me. If is there anything we can do to facilitate that, we will. And again, like I said, you've heard from the examples. Both our health centers are open as well as the aging networks to making this collaboration work in your regions. So thank you, all of you here for Region 6 and 8 for joining today's call, and we look forward to working with all of you in the upcoming future. Thank you.